Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. Well, as usual, I want to welcome today my co-hosts, Dr. Dan Lenahan and Dr. Arjun Ghosh, who are with me today. And today we're joined by Dr. Cezar Iliescu. Dr. Iliescu is professor at the Department of Cardiology and Interventional Cardiologist at the University of Texas MD Anderson Cancer Center in Houston, Texas. So welcome, Cezar.
Thank you so much, Steve, Dan, and Arjun for this kind invitation. Always delighted to be here with you all.
Well, we're going to discuss your work as an interventional cardiologist in just a moment. But first, I wonder if you could just tell us a little bit about your professional background and in particular, then, how you developed your interest in the field of cardio-oncology.
Thank you, Steve. This is one of my favorite questions. So most of the people that know me before I trained in internal medicine and cardiology and interventional cardiology know that actually I'm a board-certified surgeon. And I actually spent another couple of years in vascular surgery training. So obviously, I had a deep training in interventions, procedures, and of course, cancer, so malignancy. So I studied and trained in the biggest center of oncological surgery in Romania at the Funden National Hospital. And the majority of our patient population was an oncological population. So I early in my career developed a lot of respect and admiration for people that make really cancer history. So because of that, when I came back to the United States for training in medicine, and I had the privilege to train in the UT system, which had a rotation at MD Anderson. Early in my internship, I had the chance to do clinics and inpatient services with all these people that are, really institutions throughout the world in leukemia, Dr. Kantarjian, in hematological malignancies, Dr. Champlin, Dr. Fosella in lung cancer, and again, Dr. Brown and Dr. Wolf in GI malignancies. So I remember like yesterday, working with them, and the innovative component of the cancer research in those days, early 2000s, and the fact we had a lot of drugs that are just numbers, and they're so impactful. They were changing lives, really making cancer history. And so I always grew up with this dual love, if you say about that, about the really vascular procedures, vascular interventions, and of course, cancer disease. And when I finished and through training, I always had a feel that the way we're approaching cardio-oncology is a little bit erroneous in the sense that I had this revelation that cancer treatments are professional boxing. So then people get in the ring and they're going to be hit, unfortunately, from the disease and from the treatments, some more than others, but it's going to happen. And the question was, how can we send the patient in the ring with a suboptimal heart condition? And the general approach, and throughout the world, the approach was you go take care of cancer. When you're done with cancer, come back and I'll check you and I'll fix the heart issues. And obviously, people cannot get in ring with a suboptimal heart condition. So everything we did was with the intent of optimizing this cardiovascular condition of the patient before they get in the ring. And everything we've done, if anything, was magnified times 2, times 3 in a patient population, in a cancer patient population, because the different than general population, hematological malignancies, and all the malignancies in general have low hemoglobin. They are more likely to be tachycardic. They're more likely to be in pain and have hypertension uncontrolled because of the pain condition and all the things associated with it. More likely to have pulmonary embolism, tachycardia, mismatched supply demand, and type 2 myocardial infarction. Again, probably the prototype of type 2 myocardial infarction is a cancer patient population. So these are the really prototype of type 2 MI. If you think about and Arjun is here, every patient we see, and it's a cancer patient, has the protoplas to be a type 2 myocardial infarction. So of course, all this impact of revascularization early, all the procedures we're doing, early, will improve patients' resilience and the capacity to live through this roller coaster of cancer and cancer treatments until they're going to be cancer survivors. And then, again, I always loved this challenge of these patients. I think it was an unmet need. Again, when Dan started and Arjun and all of us, was an unmet need, because I think it needs additional dedication. You're doing two jobs at the same time. You're doing both 1 and 2, so it's like two jobs in a time slot and in a patient. So that's why I think that all the people in the cardio-oncology field have this passion about the field and dedication, because it requires additional effort and energy to fight this fight.
Arjun, you have lots of experience and questions in this area. So where do you want to start?
Yeah, thanks a lot, Steve. So we've had previous discussions on general, I think, themes of interventional cardiology and, getting into the field. And we've actually spoken, I think, to Cezar before on this, very topic. But I think the difference maybe we can focus on is one of the other interventional procedures we do a lot in cancer patients, which is pericardiocentesis. Because I think previously when we'd spoken to Cezar, it was much more along PCI and ACS and that side of things. And I thought that it would be useful maybe to look at that other side of things. So maybe, Cezar, the first question, just to set the scene, is, you work in a massive cancer institution. You have a lot of patients, obviously, with pericardial effusions related to cancer. So what is the kind of MD Anderson experience with patients with pericardial effusions in cancer, and what is your approach to these patients at a very high level?
Thank you, Arjun. A beautiful question, and it shows that I'm getting old. I started with a story. So when I was doing vascular surgery, of course, one of the first year procedures is to do a pericardial window. So this is what we did, So it was standard procedure. We knew how to do it. We're super comfortable in doing these pericardial windows as trainees. And then when I came here, and I was privileged to rotate with at the time Dr. Swafford, JB Durand, and Dr. Youssef. So we're doing these rounds, and we had to do pericardiocentesis. So of course, because of my surgical background, I was super comfortable doing this procedure. So I was always running towards doing this pericardiocentesis. So, like a firefighter, we like to get in the fire and help. So I was going towards the procedure, not going away ever. So and I was shocked, the first time they got the pericardiocentesis needle. So I saw that huge harpoon, and I was like, no way, like I was a surgeon, but we had absolute control of the procedure. We knew where we were cutting. We were visually seeing how we're accessing the space, and we had absolute control of the procedure. And out of a sudden, you're going with a huge needle. And again, we used to teach the trainees, the cut of the big needle, the pericardiocentesis needle, is exactly the cut of the scalpel. So imagine someone who's inexperienced to go with the scalpel towards the heart. And then you add another level of complexity, with thrombocytopenic patients or all these blood dyscrasias. And you say, how can you do that? And how can, of course, fine, you do it. But how are you going to train someone? How can you let someone go with a scalpel toward the heart, not knowing really where they're going? So the first change we did was we mandated all these procedures to be done with micropuncture. So the first biggest change we did as soon as I started as faculty is to implement this micropuncture technique and micropuncture approach to the pericardial space. And we had the luxury to, of course, to do those lariat procedures initially, where we had to access the dry pericardial space. So, of course, a pericardial space that has fluid in it is it's heaven. So it's easy for us to get access in that space. So we accessed with the micropuncture, and of course, we developed two techniques. Was nice because we had, a group of people that trained in different parts of the country. So, of course, we were trained with a subxiphoid approach, like a surgical approach, to get access and get into a space. But Dr. Mohar and other people in our group were trained the Mayo way, which was, on the lateral side, the apical approach. So it gives us this flexibility to have two kind of approaches, training, and do what's best for the patient. So first was micropuncture. The second one, to be able to train and be trained in both subxiphoid or lateral or apical, the way you want to call approach. And already revolutionized our techniques. And as we opened the Cath Lab at MD Anderson, then we had the addition of on top of the echocardiographic guidance, the additional fluoroscopic guidance, and all of a sudden we're feeling more and more comfortable doing these procedures, irrespective of the platelet count, irrespective of all the challenges we're seeing. And we early had to recognize some limitations, So first of all, and that's the advantage of doing it. Maybe we call it now almost triple guidance, because we have the echo, we have the X-ray, and we have also the sonocyte to get access in the space. Why this triple guidance is because you have no margin for error. So once we have a patient with a complication, the patient lost not only the fight with the cardiovascular issues, but loses the fight with the cancer. So a complication delays the cancer treatment, delays all the planning that we have ahead, and we really lose the patient. So we knew we had zero margin for error. And I can tell you, we're getting close to probably 1,000 pericardiocentesis we've done in these 15 years, and we've had zero mortality. We've not lost a patient during pericardiocentesis, which is unheard of. And it's just because of this triple guidance that we early adapted in our process, the micropuncture technique and micropuncture approach. And from there on, I'm going to go just briefly through some technicalities, So first of all, why both? When you inject agitated saline through the micropuncture needle, sometimes you do not see the bubbles. It's very challenging, the fluid is loculated. If the blood has been there for a long period of time, if you have these mixed collections, mass and fluid. So sometimes you don't see the bubbles. So then you feel reassured when you see the wire in the fluoroscopic space. The second one is some patients had previous interventions, pericardiectomy. So this new neopericardium, can lose the bubbles in this new combined space. So you're not sure ever where you are. So we saw wires, coming subxiphoid. We ended really in the neck area because the pericardium was not pristine, and we had all this contiguity between the spaces. So then you feel reassured when you see the micropuncture wire in the So it's a combination of all of those. It's a combination of sometimes, loculated effusions. You see the bubbles, you feel safe, to advance the wire. So it's a combination of all those techniques that we have. So that's the second big caveat in this procedure. So besides, again, combined approach, micropuncture, use all the elements of safety you can have on this path. And then further on, we learn, of course, that the fellows, a lot of mini details. And I'm not sure how much you want to go into details of how we're doing it. We have a beautiful paper, and we're thankful to Bonnie because she let us really publish it in JACC Cardiology. It was how to do pericardiocentesis in cancer patients with thrombocytopenia, and we've detailed over there all these little things that we do, in this process. It's a beautiful paper. Our fellows really read it before the rotation. We have Texas Heart Fellows and University of Texas Fellows rotating through us. And once they read the paper and they do it once or twice with us using that approach, they are very comfortable. Really, they leave and hopefully expand this procedure in the community.
Yeah. Thanks, Cezar. So I think that was a very interesting paper that you mentioned and generated a lot of interest. And specifically, you mentioned the point about the platelet count. So is there any platelet count that you would be kind of worried at? Because I know you're comfortable with low platelet counts. You have a lot of experience, this amazing zero mortality. But just tell us, is there a certain level that you would be worried, or what should we do in that situation?
So beautiful question, Arjun. And again, the story tells all the details. So when we started, legitimate, we didn't like those platelet counts, 10, 15, 20. And actually, we have a competition right now who's going to do the lowest platelet pericardiocentesis that has ever been done. So we're down to 4. So we're looking forward for the next challenge, but that's the lowest we've done so far. But the bottom is, of course, when we started, we're not comfortable with these numbers. We were taking patients off the table in other reputable medical centers with platelet counts 99,000 because the patients are thrombocytopenic. So we had to, again, be respectful for all the previous experience that was there. So we tried to transfuse the patients, platelet count 20,000, 30,000. We're transfusing them. And of course, it's a process. Ordering it, receiving it, transfusing it. So we're looking at a few hours. And by the time the patient that initially maybe was relatively stable could lay flat, out of a sudden in a few hours was not able to lay flat, the tamponade was overt, procedure when sort of urgent was becoming emergent. And we had all these challenges. So, and after we're transfusing the platelets, we were moving from 10 to 12. Sometimes we had situations where transfused patients initially were 20 and they dropped to 15 after transfusion, because majority of these patients with hematological malignancies are refractory to platelets. So it's a completely different patient population. So really, it did not modify the risk. The risk is high. So then we just we're making a patient stable, unstable. In that interval, we're waiting for the platelets. So we're still, again, we're not ignoring this process. We are asking for the platelet transfusion if we can. We try to hang them as we're doing it, but with majority of the situations, we just go ahead and do it in fairness. And we order the platelets in case we have any bleeding complication or any procedure-related adverse events. That being said, is our approach is for low platelets is preferably apical. Why preferably apical and not subxiphoid? Subxiphoid, we go only if the distance is absolutely super small. We're talking about, being almost accessible with a short micropuncture needle. And I'm going to come a little bit into a technicality. So we have two micropuncture needles. One is a 7 centimeter, one is a 12 centimeter micropuncture needle. So if we cannot reach the pericardial space with a 7 centimeter, we feel the distance is too much for a patient with thrombocytopenia, to where if we lacerate or destroy too much tissue and we have no control of the hemostasis, obviously all the blood is going to be collected in the Douglas pouch, and we have no idea where it is. So we can be surprised for platelet a hemoglobin drop from 10 to 5, just from simple oozing, because we touched a little bit the liver. And for whoever did surgery ever on the liver, we know that even when you try to achieve hemostasis in the past without having the sponges and we're just doing sutures, as you suture, you do more bleeding. So it's absolutely a nightmare. So any touch of the liver with a needle, it's a source of profuse bleeding. So it's very, very challenging. So because of that, we're trying to avoid subxiphoid unless we have no way around it. So our preferred approach is apical. Of course, apical distance is very small. It's just basically the intercostal space. We go very meticulous with the micropuncture needle guided. And we had a lot of success with that approach in our patient population, so preferably apical in that situation. So apical for low platelets, apical for patient on P2Y12 inhibition, apical for patient on DOACs. Again, cancer patient population, a lot of patients on DOACs. So again, our preferred approach, apical for all these situations. Unless, again, we have loculated effusions, which are posterior, very challenging. We cannot reach them apical in any way. And then again, we have to explain the patient all this risk. And again, very smooth procedure, very meticulous, almost one stick, get the needle in the pericardial space and complete the procedure. And so I think that's the biggest challenge, that really the platelet transfusion, it may be one day we're going to be able to do that study where we get, baseline coagulation parameters. We're going to do the transfusion, repeat the coagulation parameters, and see if we modified anything by doing that. But unfortunately, our procedures are at least urgent, if not emergent. So we never had this luxury to go through these steps and do it this way. So we just go ahead and we just go ahead and do these procedures. We leave our fellows to do this procedure these days. So the fellows are driving this effort. So because it's very, very important to get this message out in the community, to have these people to do this, make a difference. It's probably one of the most rewarding procedures we're doing. So as you know, we drain 50 cc's of fluid out, and the patient is better day and night. So it is very, very important to be able to do this procedure outside. Very few surgeons, if any, will do a pericardiocentesis, a pericardial window in a patient with platelet to this extreme. And we had survivorship, and when we looked at the first, I remember the first experience, which was, probably more than 10 years ago. So we had survivorship, at 5 years, in the range of 20, 30, 40% based on platelet cuts. But that means, 2, 3, or 4 lives saved, which is unbelievable. If you think about that, only did not improve mortality to this extent in the last 3 decades, only with TAVR. But nothing else was as impactful as with such a small morbidity and mortality. So I think it's a great procedure. It's a great tool. And we have a lot of people right now. We have even a hands-on course in Tampa. We've done it, for a few years. where we have hands-on, and part of the hands-on, we have a booth on pericardial effusions, pericardial diseases, how we can do it, and how can we perform this procedure safe. So again, we're doing a lot of effort. We even working on a model to mock it, because really to be able to do it. So we get this message to the community and to our cardiology community, and of course the Cardio-Oncology community, which is familiar with this approach.
Sure. I mean, that's an amazing kind of background you've given, especially the technical aspects, which a lot of people struggle with the low platelets, and going with the apical approach. Really helpful, I'm sure, to all of our listeners. I'm sure that Dan has a number of questions, but if I could just ask one last question before I hand over to Dan. You mentioned that surgeons will be a bit hesitant with low platelets to do a window. And with your surgical background, you also mentioned that you were quite comfortable doing windows, and that's kind of where you came into it from. What is the MD Anderson approach for a patient who's got, say, a good platelet count, who has a pericardial effusion? Would you normally go for a window as the first procedure, as a definitive treatment, or do you go for a drain as a first procedure?
Thank you, Arjun. Great question. So we have a nice paper we wrote about recurrent pericardial effusion. We published, I think, early this year in Frontier. So there are certain malignancies where the chance of recurrence are higher than others. But still, the first approach for us is pericardiocentesis. And the reason is our surgeons do believe that pericardial windows, even larger windows, they're still close in an oncology patient population. So our belief and their belief, again, is that in few days, 7 to a week, so a week to 2 weeks, those windows close. So are not as sustainable results as you think, and especially in lung cancer and in breast cancer, we had these patients that had windows, and we still end by doing pericardiocentesis on them because the windows close. So the malignancy progresses and closes these windows, which are, we have a new approach where basically thoracoscopic, we identify, and the surgical team identifies a place not affected by the malignancy, and they try to target those spaces for windows, which is, again, an important thing and consideration for our cardiology team. If you refer these patients for windows, you'd wish to have the surgical team to have all these possibilities to do either traditional or thoracoscopic approach to find the spot where the malignancy is not as aggressive, and you can have more sustainable results with the pericardial window in we call it unorthodox positions. It's not the traditional ones where we always do the windows. So again, we've done, I think that probably we did the math, was like 98% of the time we go for a pericardiocentesis. And even for so the first the first recurrence, we consult the surgical team, we get their input, but majority of the time we still go with another window, and we're looking probably like second or third admission with recurrent pericardial effusion when we do a window. And it's not unusual to come back again to do palliative pericardiocentesis to extend their life or quality of life, for that matters.
Oh, thanks. That's really interesting. I think, let me hand over to Dan. I'm sure he's got a number of questions lined up as well.
If you or your institution would like to have credentials that confirm your qualifications as a cardio-oncologist or a cardio-oncology center of excellence, we encourage you to consider applying for our certification exam in cardio-oncology or our certification for centers of excellence. These are the only certifications currently available in this field, and it's a special opportunity for you or your institution to distinguish yourself, recognizing your expertise in the field. More information about both these opportunities can be found at ic-os.org, or you can email directoricos@gmail.com for more information.
Oh, yeah. Well, thank you so much, Cezar. And it's always great to hear your voice and, hear about your experience, which is really important. So a couple of really significant details are, what is the benefit of keeping a drain in for several days? So one of the things when you're sort of dealing with a non-cancer related population, especially from a cardiology perspective, for the most part, they're not going to leave a drain in. They're just going to do it and, drain the fluid and that'll be the end of it. But in these patients, it seems quite important that you allow it to stop draining after a period of time. Has that been your experience?
So beautiful question. So that then was part of our initial experience. So the drains we did. So we had, of course, in the past we had this idea about using chemotherapy and using chemotherapy intrapericardal space to sort of like do like the way they do for the pleural space. We do the same pericardial adhesions in the pericardial space. And of course, there's your European experience with Teotepa and other people's experience with talk and you name it, So a lot of people did a lot of things. But that being said, we were not really comfortable to do those things. We tried a little bit Teotepa initially, but we're not able to homogeneously distribute the chemotherapeutic agent in the pericardial space. So we had more loculations than we liked. And we were basically complicating if anything, the re-access of the pericardial space. So we try to simplify it and just keep the drain in there for a few days with the intent of creating a little scarring in that pericardial space, keep it dry, make those layers attached to each between them, and then hopefully prevent recurrence. And it turned to be the truth when we did the first analysis with Dr. Mohar, with Dr. Haddad, published in JACC. When we look back, the cutoff was if you keep the drain between 3 and 5 days, we had the least amount of recurrence of that pericardial fluid. Of course, it's overall. We didn't have enough big enough numbers, to see is it true for breast cancer, is it true for lung cancer. But we got to feel that malignancies that have, of course, second determinations in the chest are more likely to have more recurrence of the disease, and we see that more often. That with breast and lung being probably the biggest drivers of the reaccumulation of this fluid. But when we looked at the recurrence, we used to, of course, you think it's a process of inflammation. So we're trying to start early, the colchicine and anti-inflammatories in these patients when we're draining the fluid. And actually what's interesting is the use of NSAIDs early, if anything, was associated with more likely having a recurrence of the pericardial effusion. And then we realized we're doing exactly what we shouldn't have done, because you leave the drain in there to promote inflammation. So the first few days when we leave the drain in, we're trying not to give colchicine, we're trying not to give anti-inflammatories, to let that inflammation happen, to let that scarring be promoted and everything. And once we have consolidation of the result, then later, which 2 to 4 weeks after that event, we start them on anti-inflammatories, on all the other elements, once we at least started the initial process of inflammation in the pericardial space to prevent recurrence. And this is kind of our current approach, to where in acute phase, we just leave the drain in to 3 to 5 days. After 7 days, the risk of infection goes up a little bit. And of course, the pericardial space is not able to protect from any significant, bacterial infections. And of course, they're all lethal. When you get the prolonged pericarditis, it's a really challenging complication. It's a death sentence for a cancer patient. So we're trying to stay out of that 7-day margin for the drain in the pericardial space.
And then you published some, at least 2 experiences before, one of which you talked about the role of cytology and whether or not that sort of implies the likelihood of recurrence. What are your thoughts on that issue?
So as you well know, the first experience was with breast and lung, and then of course the lung cancer patients with positive cytology had worse outcomes. In breast, of course, because of the advancement of disease, hormonal therapies, and all the other progress has been made in the breast malignancies treatment. It really did not modify the outcome, the presence or absence of malignant cells in the pericardial space. That being said, I think then is going to be an issue we're probably going to have to revisit in a big registry, because now with the progress with immunotherapy in the lung cancer, it may not hold true. it may be that the outcomes are similar in lung cancers with and without positive cytology. But for breast, it's been solid throughout the years. The presence or absence of malignant cells in the pericardial space did not really dramatically impact outcomes. Of course, we're becoming a little oncologists, So the more sophistication you add, of course, you can identify subgroups of patients where really, the disease is super aggressive, and even in breast cancer patients. But I think overall, like a rule of thumb, maybe for breast cancer, it doesn't mean bad news that you do not have malignant cells in the pericardial space, where for lung cancer usually is.
Yeah. So, and you touched on this before, and my opinion on this has fluctuated over the years as well, as whether to infuse something in the pericardial space when you have the drain in place. So whether you do that at the very beginning, or when you first do the procedure, or whether you do it like the next day or something like that. I mean, that's a question, but anytime you introduce something to a closed space, you're raising the risk of an infection, which you said is not good. So I guess from what you said before, you're not really inclined to infuse anything at this point.
As we got more and more comfortable with accessing this, even the loculated effusions, we have a spectacular case now. We're talking about we're a few days after Halloween. We have it's in European Heart Journal, Halloween in the Cath Lab. So basically, this huge space full of trabeculations, full of oculations, but we're comfortable getting even those. So right now, with all this triple guidance and all this additional, imaging tools, and of course with the huge progress that Echo did over the last, decade and a half, to where we almost see like images we could not believe can be seen with an ultrasound, 15 years ago, 20 years ago. So we can get in those spaces really precise, and so we're really comfortable not leaving anything in there. Then, yeah. So I agree with you 100%.
And then do you try to do any percutaneous pericardiotomies?
It's a beautiful question, and my partner in crime, Dr. Marmagiollis, keeps on pushing me, says, let's do one, and we're ready to do one. But in fairness, it's like we didn't have to do it. Of course, technically for us, it's no big deal. So it's just we're in the space, we have a wire, you just inflate a balloon. We do this every day, so again, technically it's not the issue. The reality is, of course, it's painful procedure. And we've been so successful with just a plain pericardiocentesis to where I think we're looking forward to do one. Then I'm not gonna lie to you. So we're ready. We have everything ready, but we've not got the patient, like a good candidate where this is worth the procedure. There's experience out there for sure. We've not found a good patient for that as of today.
Yeah, but I mean, I agree. I think that sort of what has become the traditional approach of putting the drain in, trying to wait, be patient until it stops draining, and then taking it out, in an expeditious way. Then this is sort of the good basic approach. And whenever you try to do something more complex than that, you kind of wonder whether it's actually going to work out very well. So.
Yeah, fully agree.
But this has been awesome. Thank you guys so much. Really a complex conversation, and one that we don't have very often. So I really appreciate being able to talk about these issues. So Cezar, what do you think? What is the message that you would want to make sure our cardio-oncology audience knows from what you're telling?
I do believe that, and I've not, and thank you, Dan, for really the question, this final question. I think the most important thing in this dialogue is to understand that we're serving the patient. A lot of time we say and we assume, we take risk, and it's not true. We do not take any risk. We're the ones, we come to work and we go home and we're healthy. So the patient assumes risk. And it is we've done and we fell short in doing a lot of procedures because of this perceived increased risk of what we do. And I do, we've been there, and again, you've taught me. So again, so you've been there when we used to call 90% high risk. The patient was dying 90% of the time. And we still did these procedures. If the patient said, "I have 10%, but give me my chest, let me fight." So I think that with that philosophy and with that training that we've been through, we respectfully explain the patient the risks. When I did this crazy pericardiocentesis initially, we explained the patient the risk. The patient takes risk. The patient said, "I want to fight," because otherwise all these patients have made hospice and they lose the fight. So we did those. And again, we talked about this. We're getting close to 1,000. We've not lost a patient. So I think that the biggest message for the community and for everybody is this, the perceived risk and the actual risk. And I think that we've evolved so much. We got so good skills. We got the training, we got the techniques and everything to where I think that we can listen to the patient. And if the patient fights, it's a legitimate procedure we can do. And one of the most rewarding procedure we've done, we've educated a lot of trainees, and the people went out in California, went out everywhere throughout the country. And they're all thankful for really saving lives. So going out and saving lives in the community. And so I'm thankful to you and to ICOS for giving us this opportunity and this big megaphone to say that this is a feasible procedure. I think that the way we wrote it in JACC Oncocardiology, it's an easy way to do it. It's in everybody can do it, and you're gonna save a life, and it's gonna be very, very rewarding for you and for the patient. So thank you again.
Super, thank you. So
Yeah,
Arjun,
thank you, Cezar.
Yeah, Arjun, what do you think about all this? Because obviously, I know Cezar firsthand and know exactly what kind of excellent proceduralist he is. But what do you think about all this in across the pond in London?
Yeah, and I think it's very interesting to hear the thoughts, especially about going for pericardiocentesis versus a window, and which is the first approach. And we have something similar in that probably pericardiocentesis is done first, and windows are left for those recurrent cases where pericardiocentesis has failed. And I think it was really interesting to hear his story about doing a pericardiocentesis with a platelet count of 4. I mean, that's pretty amazing. And, hats off to Cezar and the team at MD Anderson for doing something. And I think his paper in, JACC Cardio-Oncology really is a very nice illustration of the techniques in these high-risk patients. So I think, there's a lot to learn from him and his group.
Super. All right, Steve.
Yeah, thank you all for this great discussion. Cezar, thank you for your time. We really appreciate it. We wish you all the best in your work. We'll be sure to link to some of those articles that were mentioned in the discussion in our show notes. So best to you. We hope that you'll join us again before too long. Thanks for being with us.
Thank you all.
For more information about ICOS, you can go to ic-os.org. where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.